And what about, some were really afraid that if they said no,
Yes.
the patient would be, right? Because there are legitimate reasons. I mean, nobody wants to be scammed, but at the same time,
Yeah.
nobody wants to not deny somebody if they really did miss an appointment for a legitimate reason.
Yeah. That's a great question. What we'd advise is that the treatment for opioid use disorder is a partnership. So it's a partnership with the patient, but also with their providers. And that partnership does require that certain policies be followed, and that the patient fulfill their end of the bargain as well as the provider. And so having very good treatment agreements, having people express that they understand those treatment agreements, and having quick response to certain things like missed appointments, etc., is very important. The other point I'd like to also add is that, like we're doing now, good education of clinic staff. Many times the clinic staff feel put upon. They feel that, well, Dr. Smith really wants to do this, but Dr. Smith is here for half of the day, and we are the ones that have to handle the phone calls or appointments that were not made. And what I'd advise is that we educate the staff as well, and really listen to them, listen to their concerns, listen to ways that things could be better, because oftentimes they see things that we're not able to often see.
And is there support where people can, in an ongoing way, come talk to my staff? Because I kind of feel like it's you can get it off the ground, but it's the ongoing, how do we become this, basically a Suboxone clinic instead of the other things, is the way people start to feel.
Yeah.
And I don't.
Well, PCSS is a great resource. It's available online. They have videos, they have mentorship opportunities, they have access to a lot of the latest research. So that's certainly one place. We've also found that having a monthly brown bag series where once a month there's some type of topic that either an expert or even one of the providers presents upon, and the other aspect is a more program meeting, so having a program meeting. Some places do this weekly, some places do this monthly, where they're able to say, okay, let's bring out the protocols, what's working, what's not, what needs to be changed. Anything that can make people feel legitimately empowered, heard, augurs for best treatment.
Okay, great. No, because I feel like actually we had 37 patients initially. I feel like 34 of them went well, but it was the 3 that we spent all our time on.
And that does happen. And I also like to point out that when you look at the data on other conditions like asthma, like diabetes, they also have relapse rates, even though they're not termed relapse oftentimes. When you look at other high-intensity protocols, so a patient that's very ill goes to the ICU and they get much more resources invested. So this is similar. This is a condition that affects the brain, it affects the individual, it affects their connection to their social supports and bridges, for example, to work. And so initially it does require a more intensive investment.
Last question maybe, is there help with screening who we should take? Are all patients that need this the same? I mean, I know they're not, but should we treat them like all comers and do our best to meet anyone where they are, or do you recommend in this setting that there are patients that we shouldn't take on?
Well, that's also a very good question. You have to be able to see what your resources are, and you have to weigh those resources against the intensity of the condition that the patient is at this point in time. So if you have a way of being able to say this person is at this time very acute and they need stabilization from a residential facility, that's one way you can approach it. Different clinics have different availability of providers. So for example, certain clinics have providers only a few days a week, so they schedule their inductions on Mondays for the follow-up visit on Tuesdays. And the patients are informed that we will only have a provider these days. Medication assisted treatment, medication adjustments can only occur on these days. Despite that, despite patients signing agreements, still challenges can come up. But that's where having, as you had said, consistency and having a adherence to those agreements is very helpful.
But maybe doing it fewer days but better staffed on those days makes a lot of sense to me. We kind of felt like we had to be ready every day, and it spread us too thin, I think.
What I'm hearing from you is that you had the best intentions, but the resources as well as the knowledge to do this ran into some troubles, considering the volume of patients and the complexity of those patients and the frequency that was needed. And perhaps one way to rebuild confidence in the clinic could be to start on a small scale and really utilize it as a phase one to help develop, improve, and hone your protocols and get true buy-in from all the constituents in it. And then scale up as you can.